Welcome back to Psychiatry Boot Camp. If you are tuning into this episode and you have never been exposed to the work of Dr. Jonathan Shedler, you are in for a real treat. Dr. Shedler is a psychotherapist, researcher, and writer, and he has a way of explaining psychotherapeutic concepts that resonates on an intimate level. I am positive that by the end of this episode, you will see what I mean. And then I actually think you might listen a second time because his content is so refreshing, understandable, eye-opening, and layered. Dr. Jonathan Shedler, welcome to Psychiatry Boot Camp, and like all of our guests, I will ask you to introduce yourself to our audience.
I'm Jonathan Shedler. I'm a clinical professor in the Department of Psychiatry and Behavioral Sciences at UCSF. I'm also the chair of science communications for the American Psychoanalytic Association.
Dr. Shedler, I'm so excited to have you. I want to start out with a personal thank you. I have never had the opportunity to speak with you before, although I have truly pondered many times if I should book myself an intake with you. But I've read a lot of your work over the years, and it's been really important to me during really formative years in my personal life and formative years in my professional development. And one of the reasons that I decided to start this podcast a few years ago is that, and that I feel called to education in psychiatry, is that I am gravely concerned about the soul of psychiatry, by which I mean in the popular press, on social media, and I think even in professional level training programs, psychiatry is often reduced to checklists, symptoms, prescriptions, and it breaks my heart and it makes me really angry. And when I read your work, I feel so refreshed. And I'm so grateful that we have a thought leader in our field who pushes back against the oversimplification of the psyche. I think you promote rigorous thinking about the problems in our field and offer a deeper understanding of what it means to be human than is found elsewhere in our field. So thank you, thank you, thank you.
I try.
I will start off with a very loaded question. What type of psychotherapy would you say you practice? Would you classify your particular approach under any existing modality in our alphabet soup of therapy techniques?
Yeah. Let me push back on the question here, because I think what you just asked contains certain assumptions, and I think those assumptions are so common that they're invisible, and I think they're destroying psychological thinking and destroying the field of psychotherapy. Let me say two things. There are fundamental principles of good psychotherapy that really hold across all modalities of treatment that are effective. Some people call them common factors. I think that's a bit of a misunderstanding. These core principles derive from the psychoanalytic tradition. The very idea that you could treat symptoms or mental or emotional suffering by talking is a psychoanalytic idea. I mean, it dates to Freud in the late 19th and early 20th century. The idea that we could address suffering in psychological terms rather than in medical or neurobiological terms derives from psychoanalysis. All of the things that therapists do that we take for granted, treating people by talking, meeting for regularly scheduled appointments, inviting people to tell us about themselves and helping them to tell us about their experience more fully and deeply. All of these things derive from the psychoanalytic tradition. I think of it as it's like a great tree. And right now, everybody is pushing or promoting some modality or some brand or some acronym. And it's like people are playing around in the leaves and the branches of a great tree without really an understanding of the trunk and the roots. So, one answer is I advocate good psychotherapy, and that follows from certain principles that we could talk about. The second is I think it's the end of somebody's professional development when they turn a theory or a modality into an identity. Then the question stops being about how can I understand this more deeply? How can I do this better? How can I test what I know and, sort of sift what's works and what's helpful from what doesn't? Then it becomes about circling the wagons and protecting our brand, which is now intertwined with our identity.
Yeah, and it helps us to feel like we are smart, can help people, are competent because we can stay in what we know and we don't have to deal with the uncomfortability that comes with growth, embracing unknowns, etc.
Well, yeah, you just said something really important, embracing unknowns. I mean, it sounds glib, but I want to unpack it because it's really important. the only place real psychological change comes from is from the unknown, right? It doesn't happen unless patient, and that means patient and therapist together, enter the unknown. You could think of our difficulties are rooted in what's familiar. We repeat and recreate certain patterns. They're very familiar to us. They've often been there from the beginning. They may be invisible to us the way, presumably water is invisible to a fish, right? We have ways that we know and feel comfortable doing things. And ultimately, what we're doing in therapy is moving from point A to point B. Right? Point A is what's known and familiar but causing difficulties. Point B is something different, other than what we're already doing. We don't know what point B is when we start out. Right? The only thing that we know for certain is that traversing from point A and point B, the only the only way to get from one to the other is to traverse into the unknown. So one of the problems with what I would call descriptive diagnose and prescribe psychiatry, and also with prescriptive, therapy brands, modalities, acronyms, worksheets, is that they all disregard that truth, that the clinician comes in with an a priori plan about what's supposed to happen. It's not, recognizing existing patterns, right? Relinquishing those patterns before new and hopefully better patterns are consolidated. Right? So therapy necessarily moves into a place where therapist and patient are both, uncomfortable and lost. As soon as you superimpose it's like an algorithm or, an agenda-driven therapy, you've actually undercut something that's fundamental to the essence of psychotherapy.
It strikes me how counterintuitive it is that a doctor, a physician, would be acting in this way. Because I direct a medical student clerkship, and so a lot of the students that I teach are not going to be psychiatrists, but they have to make it through their psychiatry clerkship because that's sort of the system that we've set up. I can't imagine going to an orthopedic surgeon and my ankle is broken and they say,
Yeah, and
yeah,
that's because the analogy breaks down,
right.
and the practice of psychiatry generally, but the practice of psychotherapy in particular, doesn't fit that model. And we keep pretending that it fits, and we keep trying to, like shove a square peg into a round hole. I still teach, I taught psychiatry residents as a full-time faculty member and an attending doctor in a psychiatry outpatient clinic. I taught psychiatry residents for years. And one of the biggest hurdles in teaching them to think psychologically and teaching them to do psychotherapy is that they really had to unlearn a lot of things, right? They had to unlearn what they had learned about how to be a doctor. This is true at the most fundamental level. So we would like to create a relationship if we're doing psychotherapy, and I would even say if we're doing psychopharmacology, but doing it skillfully and sensitively, we would like to create a relationship where the patient is an active participant, where the work is a partnership, where it's not right. What's the model for almost any other kind of medical exam, diagnosis, disposition? The patient comes in, they provide us with information. Their job is to give us information, and we collect information. We take a history, we do an examination, we record signs and symptoms, we order a lab test, we gather this information, and then we come up with an answer. So the patient is in a sort of a passive role, beyond providing information and history. They're in a passive role. Once we have it, it's up to us to solve it and come up with an answer. And the patient receives treatment. All right, it's something we do to the patient.
Right, we're a plumber. Yeah,
I mean, ideally with their
consent,
active
right.
consent and
Sure.
cooperation, but it's done to. That whole model of taking it, right? If you start a psychological or a psychiatric treatment by taking a history, you are already reinforcing a model of how this relationship is supposed to work that follows this sort of doctor-patient, format. that's antithetical to what the work is, because what the work is when we come in to do what I would call meaningful psychotherapy, our stance is very different. Our stance is, you don't know the patient don't know what's wrong and how to solve it. If you did, you wouldn't be here, right? That's a given. I don't know what's wrong and how to solve it because I'm not inside your mind, right? I'm a different person. I can observe, I can infer, I can speculate, but I can't know your experience. So you don't know how to solve it, and I don't know how to solve it. But we can do something here. We can put our heads together, and maybe we can figure out a way to understand it and find a way through it together. So it's the difference between being the expert in the room who already has the answers versus joining with the patient, right? Not doing something to the patient, but doing something together with the patient to discover something really that's never been discovered before, because this person is not like any other person, right? There's certain patterns and configurations. It's not like we're flying blind and, like we come into the room and know nothing, right? I mean, we have pattern recognition going on. We understand that, mental health concerns tend to fall into certain patterns. We have the, sort of broad guidelines of, a map from a bird's eye view. But how it's going to unfold and play out with this specific person, there is nobody else like that person. So part of what I say when psychiatrists have to unlearn that, sort of medical history-taking, diagnose and disposition approach, part of what I mean is this.
There's so much humility associated with this approach, and humility is so uncomfortable, I think, especially for doctors. I wonder if this is something, if embracing this uncertainty and embracing this role of unknowing with the patient and exploring with the patient as a partner, as opposed to an all knowing sort of trip director. I wonder if it's easier with more clinical experience because I think for young therapists, for therapists that are in training, just starting out, it's so reassuring to be able to cling to a manual.
Yeah, of course it is. A manual, an algorithm, a prescription pad, among other things, serve the function of helping to manage the clinician's anxiety, right? So we can think of, theory or treatment models as, that they're serving a function for the clinician. And we have to learn the treatment models, right? We need a knowledge base. But the goal of training, isn't to follow a treatment model more formulaically. The goal of the training is to internalize it and, know it so well and understand the principles so well that when we sit in the room with the patient, we can be fully present with the patient, let go of our models, right? So people talk about, you have to get to the point where you can throw away the book. I would modify that and say, yes, that's true, but you need to own the book before you can throw it away. The problem is, this is why trainees gravitate toward manualized treatments or gravitate toward a diagnose and prescribe approach. The problem is some people never come out of that. They never move beyond it. And it takes three things to be able to move beyond it. One is we really should be selecting people for the field who have the aptitude for doing the work.
Love that.
And in many cases, that's no longer true.
Yep.
Second, when you select people for, with the aptitude, how do we overcome the anxiety of our own uncertainty, right? How do we sit in a room and communicate to the patient, but, I don't know the answers. I do know a method for finding out answers. And even though neither of us know yet exactly where this method is leading, I actually have hope and confidence, right? I believe that it is leading somewhere and it will lead somewhere that's a solution to your problems. So I don't know what the solution is, but I believe we can find one, right? What does it take for somebody to, it's not even necessarily in words, but to communicate that attitude and that view? Well, for one thing, it takes our own in-depth personal psychotherapy or psychoanalysis. We need to have the experience ourselves, not as a doctor, but as a struggling patient, right? This method works. We start off, we don't know where we're heading, but there's a method to, how we go about doing it. Things happen that we can't anticipate or foresee, and those things are very beneficial. But it can't just be intellectual knowledge or book learning. We have to really, know it in our bones. That comes from personal treatment for the clinician. And the third element is really good, high quality supervision, clinical supervision, which is happening less and less now, both in psychiatry and in other therapy, non-medical therapy professions. The field has succumbed to so much external pressure from healthcare systems, from health insurers, from economic factors. The field in the last decades, I've watched it happen, has really gotten distorted in ways that are beyond recognition. And so the function of clinical supervision was always a mentorship relationship and a teaching and training relationship with somebody who was a senior expert clinician who could fulfill the role of teacher and mentor. Right? Now the role of supervisor is often reduced, basically to a sort of administrative function. Right? And so don't have the emotional and psychological support to grow in the way they need to through their own therapy or through their own supervision. There are all these pressures, which almost always come down to, seeing more patients in less time. And all of these different forces are really pushing people not just away from doing what I call meaningful therapy, but even from ever being exposed to what it is. Right? We don't know what we don't know.
That's exactly right. You can't be it if you can't see it. You can't even imagine it, really. I think on number 3, I feel that personally. We provide supervision for our psychiatry residents. We block out essentially an hour a week to do that. Most of us, some of us have more supervisees, or we block out more time than that. That time's not reimbursed. That's just lost income. It's just lost patient time. And the system, the incentives do not support this model that you're suggesting.
The incentives are absolutely broken, and people hate when I say I've taken so much flack from colleagues, including colleagues I respect and look up to, for saying this. But it's incredibly difficult to get meaningful psychotherapy or really good quality psychiatric care within an institutional setting. It's not impossible, but it's really, really difficult because there is so much external intrusion and impingement on the clinician-patient relationship. It's like constantly an uphill battle. And often you get into the situation you just described. If the clinician really wants to do good work, they're often working on a volunteer basis, putting in time that they didn't get paid for. And of course, that's really not a fair thing to ask of clinicians. We didn't go into the field to become martyrs.
Right. Which is not to say that if you're looking for a therapist, you have to find someone that's not at an institution, or that people who are not at an institution are by definition practicing more meaningful psychotherapy. Because on the other hand, at least an institution does have some supervision and some oversight, even if it is administrative, right? I think we have these training programs now that don't offer maybe these 3 things that you just described. And so you can hang up a shingle and provide private practice, pretty low
Absolutely.
quality
Yeah, right.
psychotherapy.
Finding someone in private practice is no way a guarantee that you're going to find a genuinely skilled clinician. But if you do it in an institutional setting, you might need to recognize that the deck is stacked against it before you even walk in. You may walk into an institutional setting where the norm is, 8 to 12 session manualized therapy. Well, if you know the research literature and if you've practiced clinically for long enough, you know that meaningful therapy, right? Not the kind that's a balm or a salve or first aid for a symptom, the kind that actually creates meaningful psychological change that shifts the course of somebody's life, right? That can't happen in 12 sessions. It doesn't even start in 12 sessions, and research shows it, right? So what research actually shows, not my research, published research, is, on average, obviously everyone is different, but meaningful change in therapy begins around 6 months. Begins. In most of the institutions where people go for treatment, the norm and the expectation is that the treatment will be over long before that. Right? So we have to understand that. And then once you go down that, if you're a clinician working in that system, if you take on supervisory or administrative responsibilities, which you'll be asked to do as you get more senior, if you're any good at it, it's very, very hard for clinicians to live with that dissonance. The dissonance is, I know I'm not really doing right by my patients. I know I could do better by them. And I'm going to do this anyway because I'm compromising, because these are the institutional requirements that I'm compromising with. Very few people can live with that. So it becomes, I'm not doing right by my patients. That morphs, right? Cognitive dissonance kicks in, and it becomes, well, it's good enough for most patients. It morphs into, it's better than nothing. And then it becomes, well, no, it's really good enough for most patients. And then that morphs into, oh, this is really the standard of care. This is right. Right. And at that point, we professionals can betray ourselves.
We have to convince ourselves of that to avoid that moral injury.
Yeah. And I think it happens all around. Just, go into any established, prestigious, especially training institution, and look around.
Let's stick with the structure here for a little bit. We're talking about structural factors. One thing that I've always kind of wondered when reading your work is, do you think there's a minimum dose required to achieve the type of goal that you're talking about? So for meaningful, life-changing, I don't know what we when if we're changing someone's self-understanding, schema, belief in themselves, in addition to just symptoms, 6 months is when it typically begins. Probably no one size fits all, but is it even possible to do good therapy at a frequency of less than, let's say, 50 minutes once per week?
I don't think it is, because there's not enough continuity to get beyond the surface of things. I think meeting once a week is a bare minimum. It's actually incredibly difficult to do therapy once a week. It takes much, much more skill on the part of the therapist to do therapy once a week than to do therapy with the same person, twice a week or even 3 times a week. What happens is, a few things happen. One is, it's very, very difficult to get beyond the weekly catch-up and, the review of symptoms. How am I doing? How am I feeling? So therapy tends to stay at that level. And then that shifts the entire purpose of therapy away from change in the person's underlying psychology toward symptom management. And then we say, oh, well, look, the patient score on the PHQ-9, has improved. It sees therapy as successful. But I would say we're not doing psychotherapy. So there's a weird thing that happens in mental health that's different from any other area of medicine. In every other area of medicine, absolutely everybody is clear on the difference between medical treatment versus first aid. Right? I mean, we need first aid,
Right.
right? But there's a difference between first aid and ongoing treatment for an underlying medical condition. In mental health, and only in mental health, we're not clear on the distinction, and we do 2 things. We sell first aid to patients, and we tell them it's treatment, and they believe it. Why wouldn't they? But then worse than that, we sell that to the clinicians, to the providers, and many of them also start to believe it, especially if they've never been exposed to an alternative.
Sure, the blind leading the blind, so to speak. I want to go back to the initial question here and ask about one thing you mentioned. You mentioned that you have some objections with the language of common factors. And if I followed you correctly, you're basically saying because these are actually psychoanalytic factors that we've then taken and applied to other forms of therapy. Is that a fair enough understanding?
Well, all of the other forms of therapy, whether they want to acknowledge it or not, I mean, there's a very, very few exceptions, but generally speaking, all of the other forms of therapy are derived from psychoanalytic treatment, are renaming or repackaging time-honored psychoanalytic concepts, often pretending they're new discoveries, or their reactions against aspects of psychoanalysis, but while preserving the general structure. Let me give you an example. It's a bit of a pet peeve of mine. We say the working alliance is a predictor of outcome, a strong predictor of outcome. And in research, that's true. So it's like, oh, well, that's a common factor, it's the working alliance. But let's really think about what that means. Let's unpack that. So a working alliance has 3 elements. It means there's connection or attachment. It means there's a shared understanding about the purpose of the work, right? We're in agreement. We're on the same page about what we're doing here. It means there's a shared understanding and commitment to the methods, how we're going to go about it. Now, if you take a pretty, healthy, functioning person who's generally functioning well in the world, who's capable of secure attachments, who's capable of, interpersonal trust and, decent interpersonal relations, who generally trusts the, good intentions of other people, especially, professionals. Well, it's a piece of cake to develop that relationship. So what? Anyone could do it. I mean, a sort of high school student with social skills can create a working alliance. So now it looks like working alliance is a predictor of outcome. But what if actually working alliance is a proxy for the level of health versus the level of personality functioning of the patient? You get into the character pathology realm, or now the personality disorder realm. Now the therapist's actual skill comes into play, right? I mean, a high school student could create a good working alliance with somebody with good object relations, healthy attachment, secure attachment, benevolent worldview. That's not why people come to psychotherapy. They come because they can't do those things. So it's like, okay, so the first pillar of an alliance is attachment, connection, right? Attachment, trust, and security. The person comes in because they're not capable of those things. Now we're getting into the realm where developing an alliance requires actual expertise, right? Actual clinical expertise. So it's not the working alliance. The working alliance is, right, the common factor, but it's a proxy for something else. What is our professional expertise in navigating a relationship with somebody who is there largely because they cannot have healthy, functioning relationships? And how do we learn those skills? Well, now we're back to our own personal psychotherapy or psychoanalysis and our own intensive, in-depth, therapeutically meaningful supervision. So to answer your question, you say, why do I say I have some trouble with the concept of common factors? Well, there's one common factor front and center, but to develop that skill takes the kind of training that has always been part of this therapy tradition.
Sticking with that thought, when I reviewed your work prepping for this episode, I felt like one takeaway was that there are no shortcuts to good psychotherapy. And we just went over that, right? I mean, I really appreciate your direct answer to the question of how much time does this take, right? Yes, you have to spend time with someone to understand them and build this relationship.
And let me sharpen the question. Are we doing first aid? Somebody comes in acute distress. Can we do something to, relieve their distress in the short term? I would call that first aid. Are we trying to do something to change the underlying psychology that creates the vulnerability to that kind of distress?
You're not saying, let's not talk about your panic attack. We need to be talking about your attachment style. You're saying we can offer some first aid, but we can't stop there.
Yeah. And the answer so when I say meaningful psychological change begins at around 6 months, I'm talking about psychological change, not just, some symptom relief. And what we do now often, especially in, healthcare institutional settings, is, we go for symptom relief and then consider the job done and take the victory lap, knowing if we're good clinicians, we should know this, knowing full well, those symptoms are going to return again at some point down the road. That's the typical course when people, for the relative minority of people with major depression who have a good, meaningful response to antidepressants, right? We put them on antidepressants, they get symptom relief, they're better, but it's so common, right? Then the patient comes back a year later, maybe 2 years later, and they don't say, I'm depressed again because we never dealt with the underlying psychology. They come in and say, my antidepressants pooped out. That's the word. And then begins the chase. Oh, we'll switch antidepressants, we'll change the dose, we'll augment it with something else. And so begins this, revolving door of treatments that never ends.
I agree with your first two sort of factors that you think are required to train reasonably competent therapists, which would be selecting the right people for the field and selecting people who are willing to admit what they don't know, get into the unknown, embrace the discomfort with the patient. And I agree with your statement that basically if we took a high schooler with good social skills, they would be able to develop a connection with a patient. I think that the second part of that productive relationship, which is a shared understanding of what your problem is and what we are going to do to fix the problem, maybe this is happening like in 1% of competent therapists because I think there's such a misunderstanding, even amongst the most highly trained, right? Psychiatrists have 8 years of post undergrad training.
And most of it is devoted to things that have nothing to do with the practice of psychotherapy.
Right. I couldn't agree more, right? Because what is depression, right? How do we understand what depression is? Is this a chemical imbalance? Is this just a label? Is it a set of symptoms? And the ACGME and the ABPN have a lot of requirements about things that we need to learn in psychiatry residency. But this sort of philosophical understanding of, are we speaking the same language? Do we have the same goal?
We're not speaking the same language at all. And that's the difficulty. We've got this confusion of tongues. You mentioned depression as an example. What is it? Is it a neurochemical issue? Is it irrational thoughts? Let me offer an alternative. So depression is the psychic equivalent of fever. What is fever? Fever is a non-specific physiological response to an enormous range of possible underlying medical conditions, from the common cold to Ebola, right? Fever, the same fever could be go home, get some rest, drink fluids, call me in a couple of days if things don't, take a turn for the better, to this is a medical emergency and you need to be, hospitalized in an intensive care right now or you're going to die. But the symptom is the same. It's fever, right? Non-specific. Depression is a non-specific psychic response to an enormous range of underlying difficulties. And right, the idea that I'm treating depression and that's the job is to me a profound misunderstanding, because we have to say, okay, but if we're going to be real clinicians, right, the job isn't to deliver aspirin. The job is, can we figure out the cause of the fever? So now to come back to your question, do we have an agreement about the purpose of the work? If it's the kind of therapy I'm talking about, the purpose of the work is to change something about oneself for the patient, right? Real psychological change, to change something about oneself that's either causing difficulties or limitations that the person desires to change about themselves, and that psychotherapy could realistically help them to change. Because I see people, embarking on therapy all the time to address things that aren't actually psychological issues. Right? We don't know that on session one. So you don't come up with a treatment plan on session one. What we need is a case formulation. And, what's a case formulation? It's making the link between, the surface difficulties, right? The fever, and what's going on, under the surface that's creating the vulnerability to that. And that takes time and that takes real expertise. And the patient doesn't come in and they're on board with that change. They don't even know, where the area of change should be. Neither does the clinician, right? So it takes some time to begin to formulate a case and basically say to the patient, not as a conclusion, but as a hypothesis, here's what I'm seeing. Here's what I think I'm understanding. I think this has everything to do with why you get depressed. I think if we could address this in therapy, it would make things different for you, right? And the clinician is going to tell the patient something that likely they've never considered before. So it's not a conclusion, it's a hypothesis for mutual discussion. And now what I want is for the patient to engage with it. And maybe it resonates with the patient and they go, oh my God, that's right. I never thought about it like that. I do these things. Why do I do that? It's like, yeah, well, I don't know why, but we could answer that together in therapy if that's what you'd like to do. So what we want from the patient is they really take it in, they think about it, it feels like it fits, they elaborate on it and provide more information, and then we hone and refine the formulation. Or the patient says, no, that doesn't fit, that's not my experience.
Even better.
And just as good, certainly. And we want them to, right? And then, what we want is for the patient to correct us and say, that's not it, and elaborate on what their experience is. So we're starting a cyclical, iterative process of offering hypotheses in very, very personal experience near language and thinking about it together with the patient. And the process repeats iteratively until we can home in on an understanding that neither person had when they came in. And that becomes the purpose of the therapy.
The case formulation is not a secret little expert level series of fancy words that the psychiatrist can use to sort of put the patient in a little box and say, this is for me. Now I understand you because I'm so smart. It's something that, A, the patient's always going to read it now in the age of open notes. But really, the utility in it is that we are going to put it out in the open. We're going to shine the sunlight on it, and we're going to develop it over time, and we're going to see what sticks and what doesn't.
And it's not hypothetical and intellectual. It's rooted in data, but not the kind of data we usually talk about, a different kind of data. Because what we're trying to do is identify recurring psychological patterns, right? Sort of ingrained or, well-worn grooves in the patient's functioning that are causing difficulty. It's not a game of speculation. It's those patterns are unfolding in the session with us, right? We're not hearing about their difficulties that are happening in another time in another place with someone else. We are an observer and a participant in those difficulties. So there are the facts of our, actual experience, interpersonal experience in the therapy room. So, when the therapist says, here's what I see, it's not hypothetical. It's a shared lived experience. And the patient says, if you get into the character disorder range, the patient might say, no, that's not true. I didn't, that's not what happened. I said, well, that was your experience of it, but let me tell you what I just observed. This. But what happened in the room, right? It has to tie to something that concrete. And of course, that's what we discuss in terms of transference. Transference is a fancy way of saying the human condition is we live out certain relationship patterns that are formed. We form these patterns very, very early on in life through our earliest attachments. We continue to live them out for better or worse for the rest of our lives. We bring them into all of our other relationships. Real psychotherapy is a relationship. So the patient brings their relational patterns into the psychotherapy relationship, where we call it transference. That's where we have direct access, where we can see and recognize and begin to understand those patterns. So, in one way, especially for non-psychiatric physicians or psychiatrists who aren't trained in therapy, it sounds very abstract and philosophical and esoteric. On the other hand, it's actually very, very rooted in immediate real data.
It's very concrete in that way. I think that's a really good segue into our next section when you talked about the patient having one experience of something and the clinician having another experience of that same thing. We're going to go to break, and when we come back, we're going to talk about different forms of therapy speak. I think in this case, the example would be, this is my truth. And we'll talk about
I can't
maybe
wait.
how that is helpful or at times unhelpful. Stand by. Spring is coming to a close. We're moving into summer. The sun is out, which means lots of fun, lots of social gatherings, lots of outdoor time. Sometimes it can mean a little bit less time at home, which means your time at home is now super valuable. So you need to be both cozy and at times productive. And that's why I want to tell you about the brushed bamboo jogger set from Cozy Earth. It's so comfortable, it's so sturdy, it's obsessively engineered, and it's not just fast fashion for the home, it's something that you would reach for years from now. Same with their new clogs. Their clogs are comfy, almost like slippers, but sturdy, so that you can wear them outside, so that they support your feet as you're maximizing that at-home time this summer. Cozy Earth stands by their products with a 100-night sleep trial, so you can buy the product knowing confidently that if you don't like it, you can just send it right back. But I have lots of Cozy Earth stuff by now, and I promise you that you will like it. And they have a 10-year warranty, so you know it's something quality that's going to last you a long time, unlike a lot of their competitors on the market. This spring, give yourself the kind of comfort that lives with you all day, not just the moment you get home. Head to cozyearth.com and use my code BOOTCAMP for an exclusive 20% off. And if you see a post-purchase survey, be sure to tell Cozy Earth that you heard about them right here on Psychiatry Boot Camp. Cozy Earth, comfort lives here. Welcome back. I want to make one follow-up comment on the fever. I think a corollary of what you mentioned about depression being a non-specific symptom like a fever, and depression being a signal to us of changes that might need to happen in a person's life.
Same for anxiety, also a nonspecific symptom like fever.
Absolutely. And I think we could probably go down the list there. Having experienced this myself, and I will say, if I had not had that so-called fever, I would not have made meaningful changes in my psychological life, and I certainly wouldn't be the person who I am today. I think a corollary is the fever is not the enemy, right? The goal of treatment is not fever bad, fever whack-a-mole. You're having this problem, you're having this discomfort. It's more like, what is the fever telling us, right? Is the fever important? Should we even get rid of the fever? Have we done what we need to do with it yet?
And thank you. You just give me an opportunity to mention something that I would have otherwise forgotten. So the thing is, patients actually understand this at some level. But a paper just came out just last year in Lancet, the most prestigious medical journal of all. It was a survey of several, I don't have the numbers at my fingertips, but it was several hundred studies, several thousand patients, therapy patients. And it asked the patients, what are the things that you wanted out of therapy? What are the things that you got from therapy that were most important, that were the most value to you? And they had a list of the things that were mentioned most frequently, and these were qualitative. We didn't say to the patient, "Here are the things you could get out of treatment. Was it A, B, C, or D?" Right? That would just confirm the researchers' starting assumptions. It was just asking the patient, "What was of most value to you?" and recording responses and coding them according to categories. So they came up with quite a long list of things that patients valued. Number one on the list was insight and self-understanding, self-awareness. I think symptom remission or symptom reduction was like number 7 or 8 on the list. It was way far down of what patients said they, valued most in therapy. So then think about that. There's a real mismatch between what expert clinicians are trying to do, what real-world patients really want from therapy, and what we study as outcomes in research, where it's like apples and oranges. We do this research and we get our findings and we pretend that we've demonstrated the benefits of therapy, and we're not even measuring the benefits that real patients want and expert clinicians are trying to provide.
Right. I think when we're critiquing this nebulous idea of kind of therapy as it is in vivo in the world around us, a medical student listening might say, well, yeah, that's bad psychotherapy. That's not evidence-based psychotherapy. And you are indicting the whole argument of, well, we have to be doing things that are evidence-based because you're saying garbage in, garbage out, right? What does evidence-based even mean?
Yeah, and this is science, right? Real science. Real science is not an RCT. Hey, that's a math, that's a tool. Real science is, I think I might know something. How do I find out if what I think I know is right or wrong? What do I need to do? And any research method we bring rests on certain assumptions that are baked into the research method. If the assumptions are false, or indefensible, the research findings are meaningless. And, I would say real working scientists in the basic sciences or in that natural sciences, everybody understands this. What we have in mental health, unfortunately, is we have all of these assumptions baked in and nobody examines them. Nobody says, hey, wait a minute, all of your findings rest on the assumption that the purpose of therapy is to lower your score on a Hamilton depression rating scale. Well, that's not what the clinicians think is the purpose, and that's not what the patients think is the purpose. So in what parallel universe are you operating? In your parallel universe, these assumptions hold. In the real world, with real patients, these assumptions don't hold. Maybe we're not doing this right.
No, it's a very cogent argument. It just makes me want to jump out of my skin and take my diploma off the wall and throw it out the window, though. So we're going to have to move on because I can't sit with that discomfort too much longer. So let's talk about therapy speak. So broadly speaking, how would you define therapy speak and what is your beef?
Well, I think everybody knows what therapy speak is. Therapy speak is the language of pop psychology and social media. And I think you sent me a list of words. What was it? Everything is trauma. Everybody who offends us is a narcissist. It's just this collection of pop psychology words that are everywhere. Toxic people, toxic relationships, trauma.
Valid feelings.
Your
My
feelings
truth.
are valid.
Right.
This is a safe space.
Right.
You have insecure attachment. It's your It's your vagal nerve response. It's your mitochondria.
Well, that's a whole nother level of sort of bastardization, I think, to me, of scientific words. But things like valid feelings, why is it wrong to say someone's feelings are valid? What's the threat in that? I mean, to me, holding a safe
I'm
space
not
for
going to explain
someone.
it. I'm going to show you.
Okay.
What does it mean?
I suppose having valid feelings means that you have feelings that are real for you.
Meaning you have feelings and you feel them.
Yeah, I think that's what that means. Yeah.
I mean, it's completely tautological.
Yeah. Right.
You are having feelings, and
Right.
it's
You're
real
having
that you're having
feelings.
feelings.
Yeah.
So when you say your feelings are valid, though, right? Because otherwise you could just say
You're having feelings.
that's what you're feeling.
Yeah, right.
When you say your feelings are valid, it adds a layer of something on top of it. And you were very careful. You sidestepped it. But what do you think?
No, you're right.
What do you think, the average person, what do you think the public thinks?
They think I'm right. I should be angry.
Yeah. Right. Right. So, I mean, the word valid has a definition in the dictionary, or it has several definitions in the dictionary.
Not only that, but my therapist, who's an expert, says that it's okay that I'm angry.
Basically, valid is a synonym for, like accurate, accurate, correct. One of the definitions was, logically sound, right? Like a valid argument. Actually, none of those words, none of those concepts even applies to feelings. So the problem with this kind of word salad therapy speak, I call it theraslop,
Like that.
is it violates, right? I said all good therapy is based on certain psychological principles. It violates a really, really fundamental principle. The purpose or the principle of really good psychotherapy work is we are working to help the person to understand themselves more deeply, to be more self-aware, to be more whole, to be more integrated, to know their interior terrain, right, in ways they don't when they come in. That requires certain things as principles of working. And what it requires is that we move from the general to the specific, from the abstract to the particular. So a patient comes in, any competent psychiatrist knows to do this. Why are you here? Said, I'm depressed. Tell me about your depression. How are you experiencing that? Right? What form does that take for you? So we ask the patient to move from a global abstract term to the specifics and the particulars of their individual experience. That's just competent work. It's a long-standing understanding that when people speak in abstractions or generalities or cliches, it's a defense against noticing and going more deeply into the specifics of their experience. And we have to work with it as a defense. And that's the process of moving from the general to the particular, or from the abstract to the specific. If a patient comes in speaking in therapy speak, right, this is nothing new. Therapy speak is new, right? This is a phenomenon of, let's say, the last, 10 years and driven by largely, social media and pop culture. But the larger issue of speaking in vague terms and cliches and abstractions has been understood for generations and generations. So the patient comes in, they speak in therapy speak, it's a defense. If the therapist also speaks at that level, what we're actually doing is colluding with the defense, and we don't know anything. There was an example, I posted something about this on Twitter or X pretty recently. It was actually a patient who posted something, and she told her therapist about having meltdowns an adult woman, where she would scream and throw things and break things and have these emotional meltdowns. And the therapist, I mean, if we believe what the patient wrote, your feelings and reactions are valid. That was the word, valid. And the patient, this was what her tweet was about, the patient herself questioned that and said, but is it really?
Right, right.
And she says, no. I mean, just taking it at face value, it's absolutely incompetent therapy. So for one thing, the word was your feelings and reactions are valid. Actually, those are two completely different things. Every therapist understands that thoughts and feelings are not actions and behavior. So it's already blurring a critical distinction. There's what you feel, and there's what you do. There's what you feel, and there's whether and how you act on it. That just disappeared. And it was like, your feelings are valid. That's not even starting at therapy. It's like, therapy is, you're really getting overwhelmed by these feelings. Something like that. And the patient says, yeah, I lose my shit. I get overwhelmed. I can't control myself. So the first starting point is, right, do we have an agreement about the purpose of the work? Right, here's a place to make a little, the agreement is made up of a lot of little agreements, right? But here's one of the little ones. How overwhelming your feelings are, how much you get flooded by them, blindsided by them, to the point that you're really not in control of yourself. This is a problem for you. I said that as a statement, but it's really a question, right? It's not my hypothesis, right? As soon as the patient says, yeah, that's right, which the patient is going to say, assuming they're somewhat in touch with reality. So then our task is to understand what's going on, like what's stirring up such strong feelings, why they become so overwhelming, why you get blindsided by them. This is something you'd like to change about yourself. I mean, I'm condensing what would be a long conversation, but you sure as hell aren't going to tell the patient your feelings are valid. You haven't bypassed something in therapy. You've bypassed the entirety of psychotherapy.
Yeah, I mean, I think the most basic thing that we need to agree on is that feelings and behaviors are two different things. And you have completely thrown that out the window. It's interesting. Your response to the therapy speak is sort of, hey, Mark, words have meanings. Like, that's why we use them. Words mean something. And that didn't quite occur to me, but it's very real. It's, when you can just say, well, he's a narcissist, it's putting a label on something. It's saying, I don't have to think about something.
So the patient says, he's a narcissist, my boss, my boyfriend, my father, whatever. And I mean, a competent therapist response is, tell me what happened. Right? Again, the same principle, moving from the general to the particular. If the patient isn't tracking with that, I might even say something like, narcissist is a conclusion, a summary statement. I'm interested in the experiences and the thoughts and the feelings that led you to that conclusion. Bring me into the situation with you. Help me understand what you experienced with him. Help me understand it from inside your perspective. Right? So I want to open the door to talk about it. Anytime a patient uses a cliche and it stays there, right, the therapy isn't moving forward. That's the defense. That's what we have to work with.
I think that's going to be so helpful for any therapist listening to this, moving from the vague into the particular. Let me move into the particular a little bit now. Do you think that high quality psychotherapy is always going to have some element of antagonism or confrontation?
What do you mean by?
I mean, I would say to some degree that's therapeutic confrontation.
Okay, so
yeah.
words matter, and if you attach the word antagonism to it, right, that takes on a certain framing that's not really the framing that we want. So one of the things that we're trying to do in psychotherapy, both in the work with our patient, but internally in our own work as therapists, in our own mind, in our own training, in our own preparation, there is this horrible thing that is going on in the culture, and you see it everywhere, where making an effort to understand something is assumed to be pointing a finger of blame. So just the other day, I said something like to a patient, the patient described something they did, and I said, there must have been a reason that you responded that way. And my intent was, I'm trying to invite the person's curiosity, right? They responded the way they did, right? That's normal for them. But can we pay attention to it? Can we notice what thoughts or feelings, memories, images, sensations, etc. come up around it? Can we understand it beyond what's on the very surface? So it was an invitation to think about the reason. And the patient responded by saying, well, I think that's perfectly normal. That's a perfectly normal response. It's not an abnormal response. So the patient conflated my curiosity with blame. What we're trying to do is cultivate an attitude in ourselves and in our patients that everything is open to exploration, to inquiry, to paying attention and thinking about, And it's not a process of blaming. It's a process of understanding and coming to know ourselves more deeply. So when you say words like adversarial, it really runs counter to what we're trying to do. But I think I understand where your question is coming from, because there's something else that's really, really bad that's been happening in therapy culture, which is that therapists, a lot of therapists are sort of becoming, sycophantic yes men and yes women. And that's also not psychotherapy. So, psychotherapy is the art of helping people to see and hear and think about things that might be quite uncomfortable, and to help them to do that, without them feeling blamed or shamed, to feel you're doing this because you're interested in them, because you're interested in helping them, because you're interested in them becoming more interested in themselves, because you're trying to open the door, not to rub your nose in it or ruminate or dwell, or so you feel bad, have to feel bad about something all over again, but to open the door to being able to do things differently, to not have to repeat the same unhappy patterns and, relive the same unhappy outcomes. So, yeah, I mean, therapy is not all affirmation and validation and support. I mean, real therapy is talking about what's difficult. And that's why our patients come to us. Even knowing that it's difficult, even knowing something in them is going to fight that at every step of the way. And that's what we call, in the psychoanalytic tradition, that's what we call resistance. It's with us in the treatment every step of the way. But that's not all that's there. Right? That's a part of the patient. There's also another part of the patient that wants to know themselves more deeply. There's a part of the patient that wants to have other options about how they function, right? What they do in the world, how they solve life's challenges, interpersonal challenges, right? All of these different parts of the patient are in the mix at the same time. So we're not adversarially confronting the patient. We're joining with the parts of the patient that are looking for better alternatives, and want to understand themselves more deeply. We're joining with those parts to take a close look together as a shared partnership at other parts that aren't so well known and that are causing difficulties for them. That's how I would say it.
And in any shared partnership, you have to have difficult conversations, or there's going to be uncomfortable moments so that we can work effectively together and understand each other better.
Yeah, and what therapists are really doing when they just, affirm, validate, support, nurture, caretake, etc. I mean, first of all, they're abdicating their responsibility to do therapy, assuming they ever knew how to do therapy. And second of all, the truth is, a lot of people's practices is made up of people. I think there's some categorical distinction between, healthy personality versus personality disorder. But there's a continuum of functioning, right? And at the lowest end of the continuum, we dip into what we call personality disorders or character pathology. That makes up a lot of our practices. So we're often working with patients who are really interpersonally very difficult. And that's not an obstacle to therapy. That's why they're in therapy. And when we collude and affirm and support and tell them they're right and agree that, the problems are entirely due to their husband or their wife because that person is a toxic narcissist, and when we get, we're not only abdicating our responsibility to do therapy, we're also martyring ourselves. Right? The therapists tell themselves, I'm being supportive, doing my job. But what's actually happening in the room is they're interacting with somebody who is very interpersonally difficult. And instead of noticing it, naming it, bringing it into discussion as something to think about, they just keep sucking it up, right? So it's not psychotherapy, it's martyrdom. And that's a pretty tough, in working with supervision or teaching. I mean, that's a pretty tough nut to crack when you have somebody who's functioning in that way, and you're trying to help your supervisee to recognize, they're enacting something.
And they're ready to die on that hill if we're talking about martyrdom.
Yes, because they tell themselves, and other people tell them, they get reinforced for it, that this is virtuous. And it's not virtuous. Being a martyr isn't virtuous. and failing to help your patient change in ways that they really need to change is also not virtuous.
Colluding with resistance, yeah.
What's the yeah, exactly. What's the virtue?
Yeah. Dr. Shedler, you mentioned earlier when we talked about case formulation that all of these fancy words that we have about psychodynamic understanding and a lot of different, things that we learn in our formal training aren't really that helpful when you're actually talking to a person about I think they're helpful for our own self-understanding and conceptualization of the patient. But when we're speaking with the patient, we need to use words that are simple, precise, and make sense to the patient. And I have to tell you, if I can toot my own horn a little bit, I think one of the reasons that I have been able to develop this podcast at this point is that I really like restating the complicated things that my guests say in simple and precise language for our listeners. And I've had a really tough time with that. I've had a really tough time with that for this hour because everything you've said has been so simple and intuitive and easy to understand. So I really
But I'm actually
appreciate
talking
that.
about complex things like transference and countertransference and working with defense and transference, countertransference enactments, right? And the principles of a working alliance. But I mean, it certainly doesn't do any good to talk to our students and our trainees that way. I mean, they need to learn the vocabulary, of course, but they also need to, get it and immediately, in a real way. And it certainly doesn't do any good to talk to the public that way.
Right. Dr. Shedler, it's time for us to wrap up. Do you have any final thoughts for our audience? You've said a lot.
Yeah, I've said a lot, I guess.
How would follow me on X, maybe?
You can follow me on X, Substack, Instagram, Substack in particular, because every week I post a short essay about a topic in psychotherapy. And I've only been doing it for a few months, but it seems to be enormously popular.
It is enormously popular, and it's where a lot of our questions from today came from. So if you were interested in this, please connect with Dr. Shedler on Substack. Dr. Shedler, thanks so much for coming on Psychiatry Boot Camp. I really appreciate it.
Thank you so much. It was fun to be here.
Thanks so much for listening to this episode of Psychiatry Boot Camp. If you're enjoying the show, I'd love to know what you think. You can connect with me on TikTok or Instagram at Psych Boot Camp, or you can email me, mark@psychiatrybootcamp.com, and you can visit psychiatrybootcamp.com to sign up for our new newsletter. You can connect with the rest of the Human Content Podcast family on Instagram and TikTok at Human Content Pods. Thank you all for listening, and especially to those of you who have left a rating on Spotify or a review on Apple Podcasts. We will be reading some of those reviews here over the next few episodes, so if you write a review, you may hear your own words right here on the show. You can find full video episodes of Psychiatry Boot Camp on YouTube and Spotify. Our YouTube channel is at Psychiatry Boot Camp. Thanks again for listening. I'm your host, Mark Mullen. Our executive producers are Aaron Corney, Rob Goldman, Shanti Brook, and me, Mark Mullen. Season 4 is produced by Matthew Braddock, and this episode was outlined by Aniket Naidu. Our editor and engineer is Jason Portizo. Our theme music was generously donated by Cave Radio. I'm actually going to a Cave Radio concert tonight. I can't wait to see him. Find Cave Radio on Spotify. And other music was by Omer Benzvi. To learn about our program disclaimer and ethics policy, our submission verification and licensing terms, and our HIPAA release terms, go to psychiatrybootcamp.com, or you can also find episode transcripts and reach out to us with any questions. Psychiatry Boot Camp is a human content production. Hey everyone, thanks for watching. If you enjoyed the show, please remember to subscribe to the channel. If you'd like more episodes, you can click right here. I'd love to connect with you more, and I'm looking forward to talking to you next.